Good evening, everybody. And thank you all for coming to our event this evening, Pill Mills to Fentanyl, Tackling the Opioid Epidemic. I'm Nick Seabrook, Professor of Political Science and Director of Public Policy Events here at UNF. And tonight is the inaugural event in UNF's brand new Diverse Perspectives series, which promotes open discussion and debate of contested public policy issues from diverse perspectives and provides essential preparation for mature citizenship and an informed exercise of the right to vote. So why are we here? Tonight, our distinguished panel of experts will be discussing one of the most pressing and devastating public health crises of our time. In 2023, drug overdoses killed a record 112,000 Americans. This represented a more than 600% increase over the past 20 years. Since the year 2000, more Americans have died from drug overdoses than during the entire COVID-19 pandemic to date. And in a nationally representative survey released just yesterday, 4 in 10 Americans reported losing either a friend or a family member to a drug overdose. And I can count myself among that number. We as a nation are losing the battle with substance addiction. Tonight's panel represents a diverse set of experts with decades of experience in nonprofit advocacy, public health, neuroscience, and criminal justice. Our moderator, Rico Bowden, is the Director of Recovery Connections at Gateway Community Services, a licensed mental health counselor, and a master-level certified addiction professional. Our panel, from left to right, includes Dr. Mitch Miller, John A. Delaney Presidential Professor of Criminology and Criminal Justice here at UNF, Lindsay Volo, JD, MPA, Vice President of Health Law and Policy at the Partnership to End Addiction. And Lindsay was generous enough with her time to travel from New York to be here with us this evening. We have Susan Pittman, founder and director of Drug Free Duval. And finally, Dr. Catherine Hooper, Associate Instructor of Psychology and Director of UNF's Behavioral Neuroscience Program. Our program for tonight will include an hour for our panel to discuss tonight's topic, followed by 30 minutes for question and answers. At the conclusion of that, we'll be distributing our Chick-fil-A and Starbucks gift cards for those students who entered the drawing. So keep your questions in mind, and when we get to the Q&A, you'll have the opportunity to come up to the microphones at the front and ask questions of our panel. Thank you again for coming, and I will turn things over to tonight's moderator, Rico.
Good evening, everyone. So I want to be able to touch on just a small portion of Pill Mill, the law, and how it changed in 2011 when it was enacted, and start with the panelists about their insight on the law and the enactment of the Pill Mill law in the state of Florida in 2011. So whoever would like to take that first.
Rico, are you referring to like the PDMP?
Yes.
And okay, so that's when we passed the prescription drug monitoring program here in the state of Florida. I don't know if you guys are aware of what that is. That requires any patient who's 16 or older for a physician who's prescribing one of the drugs that's on the list, which is most drugs, to check the PDMP to see any other drugs that perhaps they've been receiving and or to report in. And the original year, it was not even it was mandated, but unfunded, a totally unfunded mandate. We had to set up a private foundation and get private money to get backing for this. And you guys, at that point, let's see, 2011, I think we had about 50,000 people die in the United States from overdose, which was shocking. But then within just a couple years, it was 73,000, and then it was 93,000, and now, as you just heard, it's 112,000. So eventually it did get fully funded, and it's fully funded now. And we saw a combination of really enforcement in the folks that were over-prescribing these medications that were literally killing people.
Okay. Anyone else?
I guess an unintentional consequence of that, though, is that now that people can't get those drugs from a pill mill, they go to the streets where they can get something that's much worse. At the pill mills, which were bad enough, at least you knew what was in those drugs. But now people have to go to the streets and they get heroin or fentanyl, they don't know what's in those drugs. And so it's had that unintentional consequence of actually more people dying. Push down, pop up.
Yeah, and that really, it shows sort of the opioid crisis. We kind of talk about it in these different waves. And so the first wave of the opioid crisis was around prescription opioids, where there was overprescribing of medications. There was fraudulent and deceptive marketing of opioid medications. And then as sort of those prescriptions became restricted, people did move to heroin, and then fentanyl infiltrated the drug supply. So first wave being prescription opioids, second wave being heroin, third wave being fentanyl. We're now in a third, arguably fourth wave, where fentanyl has infiltrated stimulants and other drugs. So it's really proliferated the drug supply. And as Catherine said, when you sort of shut off those supplies without having policies to make treatment available or other supports, that was a very important lesson from this crisis, that it really showed how weak our infrastructure was to both prevent and treat substance use. Only about 1 in 10 people who have substance use disorder and need treatment receive it. Numbers like that for any other chronic disease, like 70% of people with diabetes are getting treatment, the numbers are much, much higher. So that's a huge policy gap, and opioids has really exploited those weaknesses that we have as a country when it comes to substance use prevention and treatment.
Okay. Mitch, anything you'd like to add there?
Well, they covered most everything, but one additional, I guess, unintended consequence is that the pill mill reform here in Florida back in 2014, I moved here in 2014, so I didn't really experience it, but it was right before. And it also created or intensified a gray market for pharmaceutical diversion. So it enticed people to hoard their pills. And for those that didn't have insurance or that were accustomed to securing drugs on an as-needed basis, especially pills like Oxycontin and Meprogan and other opiates, we always think of Oxycontin right off the bat, but it's lesser ones as well. Hydrocodone is the most common. Their street value that went up tremendously because of the regulation, and then there's also sort of a ripple consequence of that as well, because for those that had been normalized into getting their drugs and not through pharmacies but on the street or through contacts, and continue to do so now that we've had the fentanyl wave. Fentanyl is adulterated and mixed in with so many substances that has to be in part of the explanation that we see of the spike in fatal overdoses nationwide.
Okay, so just to recap on the pill mill law and that it was enacted in 2011, it was based on the pain management clinics and their prescribing of pain medication or opioids for chronic pain, and having to follow up with the individuals and then connect with them after prescribing. So along that same line, we've seen just recently in the last couple of years changes in prescribing policies here in Florida as well. Someone want to touch on that about prescribed current? So that means anyone with chronic pain and is now being affected around the prescribing policies that are in effect.
Well, the chronic pain users are really under a different set of rules, but anybody who has a new acute illness or situation that occurs, like if you develop cancer now, end-stage cancer, or if you have a car accident and you have a break, or you get a surgery or something like that. The law now in the state of Florida is that you can only be prescribed initially 3 days of a pain medication, an opioid. There is a very simple waiver just by a physician's signature that extends that to 7 days. But y'all, that's based on science. It's because, like in Europe, the longest that you can prescribe an opioid is 3 days, and their addiction rates are much lower. And so it is based on science. And the risk of being a user 12 months after starting an initial pain med, if you've been prescribed longer than 7 days, is 60% higher that you'll be using a year later. So it makes a lot of sense to shorten that initial prescribing. Our folks that already were chronically using pain meds are now required to go to pain physicians, and they're supposed to measure regularly the presence of the pain medication in their system to make sure they're not diverting, et cetera, and get some other wraparound services. But there are a couple other things our state has done around that. And one thing is, a couple years ago, we passed a rule that says our physicians have to take a drugs of abuse course for their continuing education. And that's pretty significant because in the state of Florida, none of our medical schools requires a drug of abuse course. We've tried to convince the medical schools to do that, but so far they're not requiring it. Another one is changing the PDMP requirements, and the third is the limiting amount of prescribing that you can get with a new acute onset.
Okay. Anyone else want to touch on that? All right. So let's talk about fentanyl. And let's identify what fentanyl is so everyone in the audience understands fentanyl, and then we'll get into how that's now affecting not only the community, but others that are involved.
Well, fentanyl is a synthetic opioid. So the opiates, there's a difference between opiates and opioids. The opiates are the natural chemicals that come from the opium poppy. So like morphine, codeine. Heroin is a semi-synthetic opioid. So an organic chemist, way back when, tinkered with the morphine molecule, figured out how to make it more lipid soluble so it can get into the brain easier, and made it a lot more, not efficacious, but just more potent because it can get into the brain faster. And then they kept tinkering with it. These are usually organic chemists that are in a pharmaceutical company, and they're trying to do things like make it, more lipid soluble so that it gets to the brain faster and it can work better, and so that it's more potent and you can actually use less. But also they try to tinker with it to get rid of some of the nasty side effects. The opioids cause some nasty things like constipation. And then they also try to make it less addictive. So with fentanyl, what they were trying to do was make it less addictive. But every time they try to do this, it never works. And they just become actually even more addictive because when they get into the brain faster, they create more of a rush, more of a euphoria rush for the user. And so these synthetic ones, even though the intentions were good, again, another unintentional consequence. And even when they've tried to do things like make a pill time release, they don't. The problem with that is that the users can figure out, I can just smash this pill and I can smoke it or inject it. It gets into the brain really fast. And so everything that they've tried to do didn't work. And so fentanyl is one of those opioids. Other ones are things like OxyContin, Percocet, oxycodone, all those kinds of things that you've heard of. And fentanyl just happens to be a really, really potent one. It's way more potent than heroin, and I think it's 50 times more potent than heroin, and then 50 times more potent than morphine. They all work about the same, killing pain, but it's just how much of it do you need? And you need very little fentanyl to kill you.
Okay. Anyone else want to add to that?
A real simple way to appreciate how intense fentanyl is. When I give a guest talk at other universities on this topic, I have a PowerPoint slide, and it has the split frames. And on one side, it has a little pile of, think of like a little small pile of sand. It's actually the sand that was just regular mid-grade heroin that's ground up, powdered heroin. And then on the other frame, there's one speck of that pile. So that's sort of the strength equivalent. So just one tiny speck of fentanyl can cause a fatal overdose.
Okay.
I want to say one thing out of our
Go
training.
ahead, Susan.
So this is how it works. Like if you do break your arm or you have a really bad headache or something, you have these pain receptors, these opioid receptors, and they're going, ow, ow, ow. like this. You know, they're sensitive. And so they're telling your brain that you're feeling pain. And when you introduce an opioid, it sits like this on that receptor, and it just deadens that pain. And so it disconnects your brain's, you know, connection to that feeling. And so enough of those opioid receptors get covered up. And part of what happens is you go into respiratory depression and eventually death.
Okay. So can we talk a little bit about the current rise in fentanyl and what we're seeing out on the street in the current opioid epidemic?
Well, when we're talking about fentanyl that's in the drug supply, this is not fentanyl that's being made by drug companies. This is illicit fentanyl that's being manufactured and introduced into the drug supply. And so there's no, the potency of that fentanyl is very unknown, which is why it is, it can be so deadly, because you don't know whether fentanyl's pretty much been mixed in everything now, but you don't know, you know, people maybe think that they're getting a Xanax or a prescription drug, but it's actually fentanyl. And then the potency is unknown because again, there's so much variation in the fentanyl. And so that's why we've just seen, we've seen such a rise in overdoses is because of the fentanyl. And it's also really challenging a lot of our policies and other things that we have done to try to address addiction, to try to address the opioid crisis. Again, I said that the opioids sort of exploited our weaknesses. Fentanyl did so even more. And so it's really it's really challenged law enforcement efforts. It's challenging treatment efforts. It's challenging Narcan, naloxone, overdose reversal, and so it's really been a very challenging substance to be introduced and then to be so widespread in the drug supply.
Okay.
Yeah, one more thing about that is that it's really easy to make fentanyl. It used to be, you know, people have been addicted to opiates for thousands of years, but it was hard to get morphine. You know, you'd had to have acres and acres of land where they made the poppies, and then all these workers would have to extract what's called latex out of it, and then make the morphine out of it, and then it had to be shipped around the world. It was hard to do. Now with fentanyl, it was made like in the 1950s. The way you make it, the recipe is easily found. You just need a few things to make it. Anybody can get the stuff, I guess, and you can just make it in your kitchen. So it's a lot easier to get. It's cheap, way cheaper than morphine was. And again, the tinkering thing with it, people still tinker with the molecule. And so you can be creating even some new drug that who knows what the effects of those are. So even when we squash fentanyl, there's going to be something else that comes up next.
So can you stay on the fentanyl? Can you talk a little bit about different analogs? Because not everyone understands that there's a multitude of analogs around fentanyl and what we're seeing out on the streets.
I heard you talking about that earlier. You do that.
Okay. So there's fentanyl, and like medical grade fentanyl, as Laura said, it's measured, it's dosed, all that kind of stuff. You can get it in a patch, you can get it in a lollipop if you're a pediatric patient, et cetera, injection. But the street fentanyl is completely different, and the doses are unknown. There are so many analogs. You probably know more of them than I do. There's norfentanyl, there's carfentanyl. Y'all have heard of carfentanyl, right? That acetylfentanyl. But in addition, now we have something called nitazines, and nitazines are not exactly an opioid, but they do respond to Narcan and naloxone, so a person can be reversed, but they have opioid characteristics. So I haven't heard if they're technically considered an analog. Have you, Rico? Have y'all heard that? Because I don't think it's exactly, I think it's a slightly different class of drug. And all of this, if you think of the little chemical things, you know, it's just like they'll change one line on the chemical composition, and that changes the analog. And the analogs can be wildly different in terms of the strength and impact on your body.
So what we're seeing here in Jacksonville, we've seen a shift from seeing pure fentanyl to seeing acidofentanyl that was being added into some of the products that were being sold on the street. And then norfentanyl has recently now started showing up in just about everything, and that's marijuana, meth, cocaine, powdered and cooked. And so norfentanyl doesn't have or has more tolerance to it. So the individuals that are selling the product for the individual that's using the product is not overdosing as quickly as they were previously. So we're seeing a drop in overdoses, but not a drop in the substance use. So on the note of substance use, can we talk a little bit about prevention? And I'll leave that broad and then I'll narrow it down.
Sure. So, when we think about prevention, and I think I'm going to specifically talk about it as it relates to policy, and sort of what can we do at a policy level to prevent substance use. So the main thing when we want to prevent substance use is we want to delay the initiation of substance use. And that is because, you can speak to this much better than I can, but the brain is undergoing development until about age 25. And so it's susceptible to changes from substance use. And also early initiation of substance use is one of the biggest risk factors for developing substance use disorder. So about 9 out of 10 people who have a substance use disorder had early initiation of substance use. So it's really, really critical to delay that initiation of use. So when we think about that from a policy perspective, one of the most important things to do is to create a legal and regulatory framework for legal addictive substances. So that's alcohol, tobacco, and the big one right now is marijuana. That really prioritizes protecting youth. And that's because legal substances are most commonly used by youth, right? They're the most accessible. And we have a history of industry practices that have preyed on young people. And so we really need to, especially in this era of marijuana legalization, I know it's not happened yet in Florida, but it has happened now with Ohio being the 24th state. It's in about half the states now, to make sure that we are doing things that will protect youth through packaging and labeling requirements, product requirements, making sure that products don't look like candy, so they're neither appealing nor accidentally ingested. So that's one big thing. The second thing is the reasons that people use substances are really varied and they're very complex. And so when we think about prevention, we've really got to look at how you can mitigate risk factors and boost protective factors. Because the seeds of addiction risk are actually planted very, very early. And we tend to just focus on substance use prevention in adolescence, when a lot of those risks have already been in place. And so to really prevent substance use, we've got to look at a lot of issues that we don't necessarily think are related to substance use. And those are social determinants of health, poverty, violence, family stability, and how can we sort of take an approach that starts earlier in the lifespan and really focuses on healthy youth development. And I think this is a big area that we have not been as focused on in substance use generally, and particularly in this crisis. And so those policies that really address this was happening a lot during COVID, where there were a lot of bills that were, a lot of laws, the COVID relief bills, that really addressed a lot of these social determinants of health, right? They addressed housing, nutrition, income stability. They were supporting families. We were really at that time trying to help make the connection for policymakers that this is substance use prevention. And unfortunately, a lot of the support for those efforts at a political level has really waned. But I think it's really important for policymakers to understand how these efforts are really, really tightly connected to substance use prevention.
Can I add a little? Because I am a prevention person. Our organization, Drug Free Duval, is a substance abuse prevention coalition here in Duval County. You guys are all invited to be part of it. So love to have you engaged. We've done a lot of training here at UNF, so some of you may have been at one of our trainings. But I just want to, generally, I want to tell you, so for the general public, we work on environmental strategies. And the idea is that we create an environment that people end up having other options and other choices. Everything that Laura said is 100% true. We definitely need to start early on and stuff. but now you're in school, you're in elementary school, or you're in middle school, or you're in high school, or you're an elderly person living in a home of some kind, or you go to a church, or you go to a job. All of those things, we're trying to impact all of those places to create a culture of health and safety where people can choose sobriety, can choose not to use substances. So some of the things that we do is we really encourage people to store all their medications safely. There's a whole perception of harm thing when we can't say, oh, this medicine's really dangerous, so don't touch this to our children and stuff. We need to look at all medication with respect and thoughtfulness and intentionality. We need to safely dispose of all our unused medicines. It's critical, and especially now we've got medical marijuana. We have gummies, we have things like that are real attractive, even to little kids. I mean, little tiny kids. We really want to discourage drug sharing. And the thing is, even between family members, because reality is, again, bad mom story. I had 4 children, and I did share the drugs with, unlike prescribed drugs, like say it was a cough med, and it had been prescribed. And then my 3rd child got the cough. Well, I didn't want to go back to the doctor, so I just shared that cough medicine. And what I did is I lowered my children's perception of harm. So when they came to college and they had a big test, and they were going, I'm so scared for this test, and their friends said, well, here, take one of my Adderalls. That's a real scenario here, right, guys? Well, the reality is today, if that Adderall, first of all, you should never drug share. You should only take a drug that's prescribed, that bottle has your name on it. But if somebody bought that Adderall off the internet, absolutely believing it's a real Adderall, it's got a real high chance, according to the DEA, a 60% chance of containing a lethal dose of fentanyl. And we have these deaths right here in Jacksonville every day. So, I mean, this isn't no scare tactics. It's just true. It's just so different. This drug market has changed, a lot. So regarding youth, we're all about education. We really want these kids to know about the online pharmacies. We have kids that are in middle school that have been prescribed Xanax. They ran out of their Xanax. The reason they were on Xanax is because they're having family dysfunction. They didn't want to go to mom and ask for more because there's a lot of family dysfunction. So they go to the internet and they order the Xanax, and it's delivered to their house, and it has a lethal dose of fentanyl in it. So we really want to talk about, don't order things off the online pharmacies. Again, no drug sharing. We really hope that social media will begin to promote health and good ideas and options that are, there's all kinds of options for dealing with the main reasons that an adolescent uses, which are things like social pressure. You guys have pressure on you that we didn't have. I didn't have FOMO, with 10 million people all going to do this thing. You guys have that, and I don't know. Anyway, we want youth talking to youth. That's one of our strategies. We really want healthy, consistent messaging everywhere. We're going to have doctors talking to you guys, telling you the truth. We want them, asking not just, do you do any drugs? We want them to say, no, what do you do for when you're nervous about a test? What do you do when you can't sleep at night? Are you taking a melatonin? Are you sure it's a melatonin? Are you sure you know what I mean? That kind of thing. For the elderly, they need education and awareness because of tough financial situations today. Some of them are starting to order drugs off the internet and to a potentially deadly thing. We want to teach everybody non-medical interventions for dealing with pain and stress, et cetera. And we had a really significant rise recently in Duval County amongst the African American and Hispanic and Latino communities on overdoses. It went from 9% in the Black community overdose deaths 10 years ago to 23% today. So we need to message effectively in these communities too, and make sure the word's getting out and all the strategies are out there. So that's my prevention message.
Okay. Mitch?
Yeah, I have one thing to add, and that is that the opiate receptors, which you mentioned earlier, they're in your brain not because they're waiting for morphine from a poppy, but because we have in our brain endogenous morphine, which is endorphins. Those are the things that get released when we're in pain, when we're under a lot of stress, when we exercise a lot. That's what causes runner's high. So these endorphins, when they get released, they help to blunt the pain. And so what the opiates are doing is they're acting at those same receptors to reduce pain. But it's not just physical pain that they reduce the pain of, they actually reduce the pain of social pain too. So loneliness, despair. And so the things that you're mentioning about trying to prevent by making sure that people have job opportunities, making sure that people are not in despair. All of those kinds of social programs are important because it's often despair that drives people to opioid use, because it's really effective that way. They just take it away. And so if you can eliminate that kind of pressure, you can prevent some of that use.
Mitch?
Well, I don't know how much I can say about prevention because I work with justice-involved folks. So by the time I interface with them, they're already involved in drug use, and it's at least correlated, if not causal, to their criminality. But primarily, what we do is we seek to form research practitioner partnerships with sheriffs, police chiefs, departments of corrections at the state level, jail administrators that usually work under sheriffs at the county levels. And we partner with these criminal justice agencies to either affect connections to treatment, and sometimes it's connections to treatment and the treatment itself, or the treatment. So a very big starting point in this is jail-based disorder screening. Not many people know this, but the biggest provider of mental health and substance abuse services in the United States is the criminal justice system. So when you think of how many hundreds of thousands of people pass through jails, most of them there for just a fleeting moment, a few hours until they get bailed out. But even that is long enough if you have dedicated treatment staff available to do quick. We have these screening assessment tools, and sometimes they can take 90 minutes to complete them, but we have short versions that are like only 8 to 12 questions that give with pretty good reasonable accuracy whether someone should be questioned with the longer one for mental health or substance abuse, or if they have both these co-occurring disorders. So by being able to infuse screening disorders in the jail, we are able to diagnose and reroute people, hopefully away from further justice system involvement and more into a clinical treatment trajectory, and bring help to people that otherwise likely would not only not get the help, but probably wouldn't be diagnosed as needful in the first place.
Okay, perfect segue. So let's talk about access to treatment. And so great thing you talked about is jail, and something I've heard as a clinician is our jail system houses 1/3 substance use, 1/3 mental health, and 1/3 of people that actually need to be there for whatever occurrence. And access to treatment today, what can policymakers do to ensure individuals struggling with addiction have access to treatment, and that including medicated assisted therapy? Whoever would like to start first.
I can talk about the medications. So unfortunately, it's really, really hard for people to get to stop using opiates. They're so addictive. And because of like what we talked about before, because the way that they completely take away physical pain, but also emotional pain too. So most people, if they try a program where they're just asked to abstain from, where they're put into detox and they are asked to abstain from the opioids, it doesn't work very well. Most people need to use a medicine-assisted treatment. So there are drugs like methadone and buprenorphine, which act very similar to the opioids. Actually, they are opioids too, but because of the way that they're administered, methadone, for example, is usually given in a pill form, so it's oral. So it takes away the withdrawal symptoms. The withdrawal symptoms are really bad. It's like people feel very sick. They have diarrhea because they're the opposite symptoms of when somebody's using opioids. When they withdraw, they get the opposite symptoms. So they're in pain. They feel like they have a flu. They have diarrhea. And they often will go and use again just to get rid of the withdrawal symptoms. So if you can give them an opiate that helps them to get rid of those withdrawal symptoms, but doesn't give them the high, that can stabilize them. And, you know, a lot of people don't like that idea, oh, you're just substituting one drug for another, which is true. But the difference is that if somebody's on methadone or buprenorphine, which is a similar drug, it's called a partial agonist, then they can at least have a life where they can attend to their family, they can go do their job, they can make money, they can be productive citizens. There could be people in this room just being normal productive citizens who are on that kind of treatment. You wouldn't know. They just look like normal citizens. They're not out on the streets, homeless or anything. And so it's important for people who need that, and that's probably most people who are trying to recover from substance abuse, it's important that they get that kind of treatment. Some treatment programs don't want to use that because it's just another type of drug that they're using. And of course, some politicians don't like it either. So, yeah.
Yeah, and I'll just talk about those medications are very difficult to access. I spoke before about how few people get treatment, and then even fewer people are getting these medications, which are the gold standard for opioid use disorder. Not every type of substance use disorder has a medication. For example, stimulants, there isn't currently a medication for that. But for alcohol and opioids, we do have these FDA-approved medications. Now, because of some of the stigma that they just talked about, these medications have been highly, highly regulated. Okay, so it is much easier to get a pain medication than it is to get methadone or buprenorphine. Methadone can only be provided in an OTP, which is essentially a methadone clinic, an opioid treatment program. Often people have to go receive the medication every single day. They have to go through required counseling. There's a lot of requirements that are put on people receiving methadone, which can make it hard to engage with that medication. Also, OTPs aren't widely available across the country. They're often not in rural areas. So there might not even be one around. Buprenorphine was sort of created to be an office-based medication, but it is not as so that you could go to your primary care physician or another provider to get buprenorphine. There were a lot of prescribing restrictions around who could prescribe buprenorphine, how many people they could prescribe it to. That all went away at the end of 2022 when they sort of eliminated that requirement. We have not seen like a sudden increase in people in providers prescribing buprenorphine. Big reason for that is because healthcare providers are really not trained in substance use disorder. You heard Susan say that medical schools aren't training on drug prescribing. They're definitely not training on substance use, or a very, very small amount of training. So a lot of healthcare providers sort of shared they don't really feel comfortable prescribing buprenorphine. They think addiction is very complicated to treat, and it can be, right? People can get much better and it is treatable, but often people need supports and interventions that a provider may not have, like access to social worker, things that maybe could be provided in more of a specialty type of setting. And so, from a policy level, there's been sort of this goal of increasing access to these medications, but there's still a lot of policies that are standing in the way. The separation of addiction treatment from the mainstream healthcare system has been another huge policy barrier because the healthcare system is just not equipped to provide treatment. And the third major barrier is insurance coverage. So there's not only is medications often not accessible or treatment's not accessible, it's not affordable because insurance companies are not covering it. And so actually, a lot of my work and research has been on insurance coverage. So I'm like one of the very few people who feels very passionately about insurance coverage. But there are laws on the books that require health plans to cover substance use treatment, and the health plans are just not in compliance with these requirements. They're required to cover mental health and substance use disorder treatment just like they cover treatment for any other disease. But what we continue to see is people having to go out of network because there's no providers in their network. They have to pay out of pocket. At Partnership to End Addiction, we support families who are impacted by addiction. We hear over and over and over and over again stories of families who have to drain college savings accounts, take a second mortgage out on their home to pay for treatment that's often not even effective treatment. They might be a fraudulent treatment center, but it was all that they could get into. And so there has to be a lot of work done around insurance coverage for these medications and for treatment more broadly in order to make treatment more accessible.
Mitch?
Well, MAT is a huge issue in the work that I do. given that most everything we do is grant funded, we have to first win the funding, and you can't win a substance abuse award nowadays in the criminal justice context if you don't have. I mean, you've got to have substance abuse treatment holistically with comprehensive elements of individual treatment plans. There's a certain amount of focus group, or I should say group counseling. There's various evidence-based modalities, and there's all sorts of post-release planning, such as housing, transportation, employment, anger management. There's a lot of elements, but you're not going to get funded if you don't have MAT, and this is a huge problem in cutting the deal, if you will. I can't remember how many times I've been in the office. It feels like it's always rural southern Georgia, but in reality, it's all across the country with a judge or a sheriff. And when we get to the MAT part of the program, they're like, they echo that. I mean, I don't really in the justice system see methadone per se, but I see newer age evolved derivatives such as buprenorphine and Suboxone are the main two sort of new age methadones, and they just on sort of an ideological stance. They're like, nope, not going to let them get high. And I'm like, well, it's just very much incrementally to take away their withdrawal cravings, and most of all, to not get you sued if they go into cardiac arrest and die in your jail cell. And they say, I don't care. That's the tax of sin. Throw a Bible in the cell with them. And that some people have that attitude, and it's obviously very outdated. Well, that has been my reality for the most part of the past 20 years, but over about the past 5 years, it's changed a good bit. And I think maybe the reason it's changed for me, maybe less so than the rest, is because I am working in the justice system where everything is funded through tax dollars. So if there's a new medicine, and it's called Vivitrol, and it's an injection. And if we give it to someone, we usually try to time it because, I mean, we hope there's no drugs being smuggled into the jail or prison. So it's a waste to give it to you too many days before release, because you just sit there wasting the effect of the drugs while you're incarcerated. So usually within 72 hours or less of release, the person will be administered the injection, and it has about a 60-day shelf life. So for 60 days, the person, first of all, the first thing it does, it reduces tremendously drug cravings. Secondly, it blocks the brain receptors for the pleasure that you get from getting high. So if you do try to get high, you won't. You won't get high. And third, it has another offset effect, which is the positive, especially for punitive-minded judges and sheriffs, is it makes the person that mixes an opiate with or alcohol, so it's also good for serial inebriates. If you mix Vivitrol with alcohol or an opiate, you'll get violently ill. You'll get the dry heaves like you had alcohol poisoning or something. So the joke in the criminal justice system is, well, they won't try it more than once, and that sort of thing. So this is tremendous in terms of being able to keep people sober, because especially at the juncture of reentry, because that's the biggest risk period. I mean, if people often ask me, they say, if you could do one thing, well, if I could do one thing, I would send them to live not where they came from, with a different environment. But in reality, that's not the case. Most people are going back to where they came from, right? And they are going to have, people that instead of being peer support, they're going to be, risk factors, and they're going to be triggers for them. And by being under the effects of Vivitrol, even if they would cave in to those peer pressures, it's not going to work. So it's a miraculous drug. And I'll end though on saying why others probably don't speak to it. If you think of a bell curve, right, and think of the population, and most of the people in the middle, there's certain small amount of people that are very rich. And then on the other end, there's those that are destitute, and those are the people that, I mean, by the time that you're dependent on fentanyl and other substances and your justice involved, you've usually hit rock bottom. So these are the people I've been involved with. Well, nationwide, the average cost of an injection of Vivitrol is $1,200. So these really poor people that need it the most that I work with, they get it because it's funded, it's paid for. And if someone that develops a substance use problem on the other end that's very wealthy, well, they can just flat pay. But the vast majority of everyone else, it's not reachable. So it's a solution, but it's not a viable one.
So staying on that topic for just a moment, around the addiction process and someone that's recovering from opioid use disorder, they'd been using opioids for quite a while, talking about triggers and things that could trigger them to want to use again. Can we talk about maybe the neuroscience behind that, such as a really good meal or even sex and how that floods them? And that could be a re-triggering event to make them want to go back out and use again?
Yeah, so when people are abusing a drug like that, one of the things that it does besides the opiate receptors that we talked about is it also, in this drug in particular, well, all drugs of abuse either directly or indirectly activate dopamine, the release of dopamine into a particular area of the brain that we call the reward area. It's called the nucleus accumbens. And so anything that activates that's really rewarding, good meals activate that, sex activates that. Even if you're really thirsty and you have a drink of water, that activates that system too. So another thing that dopamine does, though, is that it works with your memory to kind of tell you this is something salient, this is something important, and it helps you to kind of make memories of those things. And so if somebody's using drugs and has a really good experience and you've had that dopamine release, then anything that happened that created that's going to be a memory that gets kept. And so there are other things that happen too. The brain changes based on our experience. We call it plasticity. And so through this process of being of abusing drugs, the brain actually changes and so creates cravings. And so people will have cravings for these drugs. And that's really kind of the issue, is that the brain has sort of relearned that this drug is something that you really, really, really want to search for, that you really want to go after. And that's why people destroy their lives. By searching for that drug that they're craving instead of doing something more productive. So these triggers then will cause this craving, and the craving itself turns out to be rewarding, actually, and can be even more rewarding than taking the drug itself. So anything that is associated with the drug use that can then become a trigger that then causes that whole process of craving and reward.
Thank you.
And that's why when you were saying reentry is such a dangerous time, right? Because even if someone has been not using opioids for a period of time, like a period of incarceration or an abstinence-based detoxification program, or even like residential treatment, their tolerance to opioids has gone down, but those cravings, right, are still there. And so there's an incredible risk for fatal overdose upon release from incarceration, particularly, which is why, and especially if either from a period of detox or from providing medications in the jail, if there's no connection to those services in the community upon release, and they aren't there for a variety of different reasons, then that puts people at really, really big risk for overdose. And so from a policy perspective, one thing that we've been trying to change for a long time at the federal level is to make sure that people are enrolled in Medicaid, so that they're able to get connected to treatment and have it paid for, right? Because you're coming out of a jail, like you don't have money or insurance or a job or any of that. But making sure that people are connected to treatment, because especially in that 2 weeks post-incarceration, the risk for fatal overdose is incredibly high.
Okay. So let's continue with that trend. So let's talk about treatment funding and insurance coverage and how policymakers can help ensure people have coverage in order to receive treatment.
Sure. So I touched on this a little bit. There are laws. There's a federal parity law that is just, quite frankly, not well enforced. There's not a lot of teeth behind it. There are different states also have different requirements. Insurance is really complicated, though. There's federal payers, there's private payers, there's Medicaid. So you have like federal regulators and state regulators. You have all these different entities involved. And what that's really done is just kind of created this diffusion of responsibility. And the state can pass a law, but it's only can cover like about 30% of people in the state because most people have insurance that's regulated at the federal level. Either through like Medicare or Medicaid or through private insurance. And so it's really been difficult to sort of pass laws that kind of capture like a large number of the population. And the enforcement framework that's currently in place for these laws requires people to come forward and file a complaint that their insurance company has denied them care. And these claims denials are happening at a point of complete crisis for an individual and their family. So the last thing that they have time to do is go through a burdensome denials process. So the enforcement framework around these insurance laws just doesn't work. There has been slow incremental change at the federal level to try to strengthen them, but the insurance industry is an incredibly powerful well-financed industry, so it has been really hard to make changes to get better enforcement of those laws. You also need to have insurance coverage, right? So people get insurance coverage a variety of different ways, but for states like Florida that haven't expanded Medicaid, you still have a high uninsured population. And Medicaid is a huge payer of substance use disorder treatment. Jails and prisons are the biggest, but Medicaid pays for more substance use disorder treatment than commercial health plans. Also, the reimbursement rates for substance use disorder treatment are abysmal. They haven't moved in years. They don't nearly cover the cost of treatment. So there's really no incentive for providers to provide this treatment because they don't get paid enough to do it. And as I mentioned, they're already not trained in it, so they're coming in with this perception. It's really hard and really complicated. So it's like, I'm going to treat this really hard and really complicated disease and get paid nothing for it. I'm not going to participate with insurance. Plus, there's all these other barriers around network participation. So you see really, really high out-of-network utilization rates for substance use treatment and quite frankly, for mental health treatment. So there has to be a lot that's done there. And then around network adequacy, which is these insurers are supposed to have an adequate network of providers to provide services to members, but we know that they have ghost networks, meaning they've got people that they say that are in their network that aren't in their network, or that have a disconnected phone number, or they just quite frankly don't exist. And so there's just not enough, the insurance company is not doing enough to create sufficient networks, but at the same time, there's also workforce shortages because there aren't enough providers out there. So there's certainly a lot to be done on the insurance front.
Okay, Susan?
I just wanted to speak to a couple of innovative projects happening here in Jacksonville. Is that okay? One is to try to kind of fill this gap. First of all, there's Volunteers in Medicine, VIM. If you've never heard of that, it's amazing, completely free. You can look them up, Google them, whatever. They have a wide range. There are all kinds of providers that provide some free therapy, substance abuse treatment. People like Fresh Ministries and several peer support things. But one of our most amazing projects is called Project Save Lives. And Rico actually heads that up. It is an amazing program. And so here's the bottom line. When somebody gets reversed from an overdose, hopefully they've agreed to go to the hospital. When they show up at the hospital, it used to be that they showed up to a police officer because they had broken the law, right? But now they are introduced immediately to a peer, and that is a person that has lived experience as an opioid addict or having faced addiction. And it, as Rico says, they share a language of the heart. And so there's a whole difference. And what Rico and his team had to do is really go in and get the mindset of the emergency departments to shift, because it used to be in the emergency department, treat and release, treat and release, treat and release. If we have to do inpatient, put them inpatient. Well, people that had overdosed were not, unless they had lots of other issues like cardiac issues or something, it was release. So the goal here is treat and refer, treat and place, treat and get that. And it's amazing. This is a partially city funded, partially, I mean, you can probably speak more fully to it, but the patients get buprenorphine, as we've talked about, which is so expensive and so difficult to access. And they have, and I'll just brag on Rico a little bit, over 60% acceptance rate by the folks that have had the option to participate in the program. And I want to say the recidivism is very, very low. Is that correct?
Yes.
We've only lost a couple people in the program over 4 or 5 years. So it's really amazing. This is going on right here. So any emergency department that somebody you know and love and care for happens to get taken to will have this option if they've experienced overdose. Another one that we have is the Jacksonville Sheriff's Office or co-responder program. And this is partners with it's a partnership between JSO and MHRC. And so there's a mental health clinician, a real clinician that rides with the officer, and all 6 of our health/JSO zones are covered with this program. And it started a couple years ago. It grew. I mean, it was only in one program initially. And again, what the mental health person is able to immediately assess, and it's very heavily substance abuse situations. Rico's team keeps 2 detox beds open at all times for this, right? And so free of charge. So there are, Jacksonville's working on this stuff, y'all. We by no means have mastered it, but we are doing some things. And so we're trying to fill some of those gaps.
So Mitch, I want to touch on something since you've talked about criminal justice. Can you talk about criminal justice reform?
Well, it's a little bit of a pointed question when you say reform, because that sort of suggests that there's the need for such. And we see this nationwide crisis, this opiate epidemic, but the fact is that there's, by way of reform, I guess there's educational efforts, and clearly there's public awareness campaigns that are going on. That's not really under, this 3-ring epidemic circus. That's not one of my rings. Criminal justice, that's, that's for public health and social work and other areas. But there are probably, under U.S. DOJ sub-agencies, and by that I mean National Institute of Justice, U.S. Bureau of Justice Assistance, Office of Juvenile Justice and Delinquency Prevention, Office of Violence Against Women, etc. All of these sub-agencies have 2, if not 4 or 5 different funding streams that are either directly or indirectly speaking to minimize the epidemic. And then there's also a tremendous amount of funding available through HHS, the SAMHSA. I sit on the NIDA, National Institute of Drug Abuse review panel each year that gives out about $330 million. I sit on a particular stream that focuses on trying to bring services to rural, underserved areas that really don't have anything except maybe one social worker in the whole county. Oftentimes not even a hospital, just an acute care facility. And that kind of reminds me of something that, this is a little bit of a tangent, but I think, and it really, it's not reform per se, but I think it accentuates and underscores how vastly important this topic that we're discussing here tonight is. Because when in a lot of these rural counties where we work, well, since the COVID crisis, you've also heard that, there's been a nationwide crisis of a manpower, staff shortage for law enforcement, and that's generally true. So a lot of places have gone to where, gone from 2 to maybe only 1 officer at night shift. They usually work 12 shifts, and some even are so short staffed. I won't say which county it is in southern Georgia, but they're down. It's literally Andy Griffith and Barney Fife. So they only have an officer every other night for the night shift. So that is, there's nobody other. There's a dispatcher that can call and wake the sheriff up or the undersheriff if something happens. But every other night for 12 hours. Well, even the nights that the guy is working, okay, if there's an overdose or a mental health crisis, he has to do a transport to the acute care facility in the county, because there is no hospital where the person will be held until 8 o'clock the next morning, where they'll be transported to Savannah. And because that facility has no security, by policy, that sheriff's deputy has to stay there with the person. So if you're on a 12-hour shift and you have to call the first 2 hours in, that means you're going to be sitting there for 10 hours or 9.5 and 30 hours. 30 minutes of driving to get there, right? So, but the point is, the county has no law enforcement presence for those 10 hours, right? So there's implications, there's collateral consequences to people that aren't involved in the dealing or the use, or, I mean, just, you know, we're all in a way sort of innocent bystanders of this catastrophe.
Okay. So I want to spend maybe 2 minutes and then just walk into opening up the floor for any kind of questions. Lindsay touched on it a little earlier about addressing root causes around poverty, unemployment, mental health, and lack of access to healthcare. What can policymakers do to help address these for individuals that are seeking either treatment or in that environment? Because really, through my business, I've met a lot of individuals through generational use. So they learned how to either use heroin or something else from a family member. And so what can policymakers do to help address some of these issues that we're seeing that could be known as a root cause?
Yeah, so I mentioned this before. You know, policies that address a lot of the social determinants of health that we know are huge risks. And you're right, this is, you know, addiction is very much a family disease. A lot of it is also hereditary. So people who have a family history of substance use disorder, and now it really touches all families. You know, that it is something that does travel, and as well as trauma from that untreated substance use. So that's a big thing. Is again, substance use treatment, especially for parents who are struggling with substance use, so that kids grow up in a healthy and stable environment. Policies that address mental health, because we also don't, you know, mental health often goes untreated and people medicate with use substances to self-medicate. You know, policies that also, you know, parents and families play a really big role in promoting resilience, right? And as I said, like addressing, sort of planting those seeds of resilience at a very young age. It's very hard for them to do that when parents are dealing with so many different stressors. So even policies like paid family leave and affordable child care are things that are really important to foster this healthy and stable environment that's really important for kids to grow up in, and reducing this substance use risk. Another policy, and we actually spoke about this before, is having like engaging and accessible after school and weekend activities for young people. We were talking about what's known as the Iceland model. And in Iceland, they had very, very high rates of underage drinking. I believe it was in the 90s. Very, very, very high. And so in order to address that, they basically made extracurricular activities widely available, all different types of activities, right? So sports, music, rock climbing for people who are more risk-seeking, yoga and meditation for people who like maybe were more anxious. They also had other components. They instituted a curfew. They kind of required parents to be very engaged, and the rates of underage drinking dropped precipitously. So, you know, there's really, I think we need to really take like a much bigger view and understand how connected a lot of these social determinants are when we're thinking about substance use. The other thing is this healthy youth development, resilience building, all these efforts, they not only prevent substance use, but they prevent a whole bunch of other negative outcomes. So there's a lot of bang for your buck in sort of addressing this, right? Where you don't then, you know, they'll reduce bullying, they reduce violence, crime, yes. So it's all the same strategies are you know, for substance use prevention as well as others when we're kind of focused on these social determinants of health.
We're currently working with some youth here and a group called Duval Collab, and I will tell you that they last year did a summit, and they kind of dug into what their root causes were. They're from 13 different schools across 3 counties. And they honed in on 3. They said there was academic/future pressure. And we're like, what does that mean? You know, what do you mean about that? And they're like, well, my parents want me to get really good grades, or I don't know what I'm going to do when I graduate, or, you know, a whole host of things around this. These are high schoolers, so post-high school. The second one was they called it social pressure. And we said, is peer pressure? And they said, well, not exactly. It's more like social pressure, which they felt like had been really amplified by social media. So that's kind of a new area. We're not really sure. We're just starting to try to figure out what that means and how to address that sort of core root cause. And the other one is they claimed that mental health issues, that they were self-medicating. They were trying to seek their own solutions to mental health issues. And so, we're trying to work with them and their families to try to come up with, kind of using the Iceland model, with some ways to address those core root causes. And if you guys have some ideas on other root causes, we'd love to hear it. The other thing is ACEs, which is basically what you're talking about. You guys know that's adverse childhood experiences, right? And there's quizzes all over the internet. You can go in and take. It's a 10 segmented kind of area. And data shows that if you have 4 or more ACEs in your background, that you are far more at risk for a variety of things, even physical health issues, during the course of your life. You don't have to stay there though, because there's a lot of stuff you can do. So anyway, that's what we're doing on trying to do.
Thanks.
I wanted to mention 3 things. One is, I think that maybe Lindsay mentioned that there's a genetic component to it. And so just knowing that probably about, 50% of the explanation for why people use is their genetics. And just because of the way that your DNA codes particular proteins in your brain, that your receptors are proteins, then you could have these receptors, these opiate receptors and dopamine receptors, that are just more susceptible to being activated by these drugs. And so it's more rewarding for you maybe than it would be for somebody else who doesn't have that kind of genetic background. So that's part of it. So people who know that they have those genetics, maybe that there could be interventions early on for that, or they could at least know that they probably should stay away from the drugs. Another thing I wanted to mention was a famous experiment called the rat park experiments. And this also goes to what Lindsay was talking about, is that rats will self-administer drugs, the same drugs that we abuse. They will do the same thing. So you can hook them up and they will drink water that has these drugs in them. So they will self-administer opiates. But if you put a rat in what's called a rat park, meaning an enriched environment where there's things to play with, like straw to burrow in and little cans to play with and running wheels and things like that, they will... Oh, yes, and other rats to play with too. They're a lot less likely. They will self-administer a lot fewer of those drugs than rats will who are in an impoverished environment. So we probably do the same things. And so an impoverished environment is one of those risk factors. And then the other thing I wanted to mention, and this goes along with it, was just one thing that we could do is just provide more job opportunities and job training. A lot of these problems happen in rural areas where there's not a lot to do, and and perhaps industries have left, there aren't really great jobs. And so just getting people more fulfilling life, whether that's with their jobs, with their families, with their friends, or just more things to do, those will take care of some of those risk issues.
Okay. Mitch?
Well, again, for me, prevention is a little after the fact, but the best thing that I guess that we try to do by way of prevention or intervention, and when you think about it, all intervention is prevention for looking forward, right? Is to ensure that the treatment programs are designed around evidence-based practices. So instead of that of treatment strategies that people were trained on years ago that now maybe science has proven to be less effective, to make sure that those aren't continued just because it's easy or someone's familiar with it. So that's a huge thing. And if I could share a brief narrative on one evidence-based practice that we sort of learned the hard way. So about a couple of years ago, I was over in Jasper County, Missouri, that's Joplin, where the real bad tornado hit a few years ago. And through UNF, we have sponsored a couple of treatment initiatives that are both opiate focused, one a veterans treatment court and the other a co-occurring treatment court for people that have substance abuse and a mental health issue. And when we evaluate these programs, we do the traditional statistical analyses of things like relapse, recidivism, treatment continuation, post-release, employment, all the basic things, right? But we also want to understand, so we put a lot of emphasis on the qualitative. So we use a mixed methods evaluation strategy. So we always go there. So if it's if it's a transitional program where it starts during incarceration, we try to at least see them one time while they're still locked up, and then we'll see them multiple times usually thereafter in a community context. Well, on this particular visit, something happened. It's the only time this has happened. I've been doing this about 25 years. So I was there with a colleague who's on the faculty at Clemson and one of our UNF master students. We were the interview team. And on the other side of a table, half of one of these tables, there were 5 of the clients or inmates, depending on which vernacular you want to go with there. They're really both. And we always want to get feedback from the program participants directly in terms of what's working, what's not working, so we can give hopefully meaningful feedback. Well, I wondered over the years if the feedback, I understand that the partnership helps the agency win the award and get the resources. But I've often wondered when we publish all of we write the technical report at the end that goes back to the agency. I wonder if they even read it, and then we try to convert that to publication for the academic world. But I wonder if that isn't just writing for other professors. Well, on the particular visit that I set up a moment ago, we were asking the questions during the course of this roughly 30-minute interview session. All 5 of them, one by one, passed out on the table in front of us. So by the end of it, everybody's head was on the table. Most of them eased on down. One kind of did a wobble and then actually made a loud thud, and I hope they were okay. And so we woke them back up, and 3 of the 5 had admitted to injecting right before coming in. And after our evaluation session, they had to go into a regular weekly treatment group session. So what we learned is that this was a grant that had just been funded, but it was on the tail end of COVID, so there was slow enrollment. So the local agency folks were real stressed and worried that the federal agency, the funding agency, was going to be upset that things were off to a slow start. So they rushed people into treatment. So the lesson we learned is you can't put people into treatment no matter how, and this program was designed for high risk, high need people, but you can't rush people into treatment unless they've been detoxed first, right? So usually these grants run 3 years, and at about the halfway point, we give a midterm sort of feedback report. Well, because this was, I've never seen it in 25 years. All 5 people passed out in front of me. So I wrote about a 4 or 5 page account of what happened to the court administrator, and they suspended the program and didn't admit anybody for about 2 months, revamped it to include a detox element. So so my main point is make sure the programs are around evidence-based practices, of which detox clearly is one. And also it was, sort of a feel-good moment for the research team to see that, somebody was really listening, and we weren't just, checking off a box, but that it was a real meaningful, interactive, engaged process.
Right. Thank you. So I want to be able to open up the floor, and if anyone has any questions that they'd like to have answered by any of the panelists, please come up. Come on up, please.
The question was, what is being done to combat some of the real predatory treatment programs that are out there? They lure people in, promises of great things, and then there are not evidence-based practices going on, and oftentimes people spend a lot of money and don't really get helped. And so fortunately, I don't think any of our Jacksonville treatment programs are in that situation right now. Do you want to speak to it?
Yeah, I know just a little bit about it. I think it was primarily in Palm Beach County. And they did pass, and it was around sober homes and treatment providers, and there was a lot of kickback. Just fraudulent. But the district attorney there, I believe, and the state may have even passed a law around this, sort of addressing the fraudulent practices that were going on. It's not just limited to Florida, though. It's happening in other parts of the country as well. A lot of that has to do with when I was talking about the separation of addiction treatment from the mainstream healthcare system, right? So there's much less regulatory oversight, licensing requirements, there are certain standards, but often there don't have to be trained medical providers. It depends on the state, but that's a product of having the separate treatment systems, as well as, you know, people who aren't able to get treatment at home, right? They kind of get on the internet and look for anything, and oftentimes people are really desperate to get to go into a treatment program. And so that was particularly a really big issue like 5 or 6 years ago. And I'm not, again, in Florida, I'm not as familiar as what's been going on, but I know there were also different ways they were leveraging different consumer protection and other laws to shut down those operators.
I want to put in a little plug for the Sober Living Alliance here in Duval County. It's headed up by a really amazing team of people, particularly a young woman named Angie. What's Angie's last name? I don't remember Angie's last name, but they are absolutely to be certified. They get a state certification. They also created an even more stringent one for the North Florida region. And to be a member of the organization, you have to follow all those rules and regulations, et cetera. So I'm very happy with how they've responded regionally here.
And our organization actually has a program. They work with the SAFE Project to create a treatment locator in order for families to know. And we have a lot of resources on our website, which is drugfree.org, about what to look for when you're looking for a treatment program and questions to ask to make sure that this is a credible and not fraudulent program.
So basically what was happening down south is there was a lot of patient brokering. So the housing provider or the treatment provider were shipping the patients back and forth, charging the insurance company for multiple drug tests or different modalities that they were using. And so each party was benefiting from that. And through that and being able to address those issues, it's really tightened up a lot of things for the state of Florida that are able to do with individuals that are in a treatment episode and wanting to continue on. So Susan touched on it for just a little bit, which is the Sober Living Alliance. And so there's a Florida Association of Recovery residencies that individuals have to be certified under, and a lot of the federal funders will only allow you to support that individual in that type of housing that receives that type of certification. And there's very small amount of individuals in this city of Jacksonville, and you all know how big we are, very small amount of individuals that have that certification for those individuals. And one of the great things about the Sober Alliance, they worked with the program Project Save Lives. It was in the inception of 2017. And so they also not only support underneath the certification, but they also support the individual with medication. So a lot of the recovery homes don't support that continuation of harm reduction with that medicated assisted treatment. And oftentimes these individuals in recovery will find themselves in a recovery program and be shunned. And that's whether they're on medicated assisted treatment or psychotropics, addressing any kind of mental health. And because they don't feel the individual's truly in recovery if they happen to be on some kind of medication. So there's a lot of barriers that individuals do come up against when they're traveling through not only the treatment, but also through recovery itself. Anyone else? Yes, you can come on up. Thank you.
Good evening. My name is Rose, and I'm a final semester nursing student here at the university. So my question is more from like a clinical standpoint. Oftentimes, like patients we have admitted to the hospital are there for another problem, and they just happen to have substance abuse issues. And so when we say, "Hey, we're not going to give you the pills you want," or "Hey, we're going to go ahead and put you through alcohol detoxification," they view it as a punishment, sort of, from us that we're not giving them the support they feel like they need. So I want to inquire about the strategies you think us as healthcare providers can use sort of towards these patients, saying, "Hey, treatment isn't a punishment. We're just doing what we can to help."
So let me step in for just a second. I want to identify I'm a person in long-term recovery, and I want to kudos to the UNF nursing department, because they approached me many years ago for a group that I founded in 2003 about having the nursing students come into the environment and really understand what's happening in the recovery community. So I'm super excited to hear you share. So go ahead, Susan. Lindsay.
I was going to add, and I'm sorry, I can't speak to it from a clinical perspective, but our organization supports family members who are supporting a loved one who's impacted. And so it's a very similar, I think, kind of conversation. So we'll provide training in like motivational interviewing. There's another method called CRAFT, right, which is sort of like moving someone towards treatment. And so I don't know if maybe in the clinical setting, similar types of interventions or messaging strategies might be helpful, but that's really what we do with families, because families have often been, they've really been stigmatized. People with substance use is highly stigmatized. Individuals are subsidized as well as their families. And so families have really been given a lot of messaging about enabling and letting, kind of kicking their family member out, and just really punitive type of approaches. And so really trying to change that conversation to speak, just in a more, like, just to enhance communication with the loved one. So maybe similar methods could be used in a clinical practice. And we can actually, if you'd like to connect, because some of my colleagues do clinical trainings as well for providers, so they might have some information that I could pass along to you as well.
Yeah, so Product Save Lives is a program that works in 6 different emergency departments here in Jacksonville. And we engage the individual not only in the emergency department. And we originated in 2017 to address the opioid epidemic in the city of Jacksonville, which a large portion of what we are doing is funded by the city of Jacksonville. And we're also funded by the CDC, and then also a federal bill that provides rich services. That I have over 25 individuals that work for me. 22 of those individuals are actually in recovery. And so they're able to have that conversation, that language of the heart that Susan talked about, to be able to help that individual. What's most important is to let that individual know that you're willing to support them through whatever transitional change they're wanting to make. Oftentimes in that environment, they're really mad about it. And I've met many where they were just mad because their bud was ruined because of Narcan. But the reality is, if Susie keeps coming back to your hospital for a broken leg or broken arm, and you've realized that she's overusing her medication, then obviously a conversation needs to be had. And she may not be addicted, but maybe there's a conversation of maybe how to take the medication. Could oftentimes, it's Susan talked earlier, is sharing medication. So is it really Susie's medication, or is it she getting it from someone else? We hear about how people are going to open houses that are when individuals are selling their home and their medicine cabinets are being raided because of, that's what people are looking for. But having the conversation is a step towards some kind of change. And it may not be abstinence, it may just be harm reduction. And that's important because an individual often is left alone. And when Lindsay talked about it, it's family support that really helps. And Susan touched a little bit about it. You can't take a dying plant out of the soil, move it to a new environment, make it all better, and put it back in the same soil. The reality is addiction isn't a spectator or a sport. The whole family gets to play. And so you really have to address the whole family systems in order to really help that individual. And oftentimes, we've met individuals in the hospital who don't even know what recovery looks like. The normal thing for them to do was to use. That was normal for them. And so having someone that having that conversation, and may they not be happy at that very moment, but it gives them a moment to realize, obviously, they're doing something that's not good for them. And we're talking from a medical perspective there. And getting them in the right direction and just having information. And I'll make sure you have enough information before I leave. So
Thank you.
thank you. Anyone else? Yes, sir.
Hi, my name's Jake. Thank you guys for being here today. I wanted to ask a question about harm reduction, specifically needle exchanges, safe injection sites, and drug testing availability. Those are generally not attractive policy decisions to make. I was wondering if you could speak to the efficacy of those programs and your resistance to such policies you find in prevention policy and law enforcement.
Well, there's a lot of resistance in criminal justice because of the conservative ethos and ideological orientation. But I don't want to sound entirely weighted on the clinical side, because it is important that we balance public safety with offender recovery concerns. But the one thing that you left off the list of examples of kind of harm reduction things that I find to be the most controversial which I think would be one of the lesser ones. But at the point of release from custody, which I think this would certainly be a first automatic go-to in terms of fatal overdose prevention during that risky window we keep talking about. But fentanyl distribution testing strips, which are super inexpensive. I mean, like, I understand, like, I can say, well, Vivitrol, like, that's not a practical solution at $1,200. Well, I mean, this is like at 1.2 cents, per strip or whatever. So that's one thing. But again, all of my answers are sort of through the lens of justice-involved people, which I don't think necessarily generalizes well to the overall population.
Just on the evidence question, so syringe exchange programs, well studied, highly effective. They are still illegal in some states. I checked quickly, so here in Florida, they are legal, but they can't use any government money. They have to rely on grants and private funding, so it makes them obviously very difficult to operate. Supervised injection or supervised consumption sites have not been studied as much in the United States because they are illegal. They are operating in New York City right now, or overdose prevention sites. They have many different names. So there's sort of emerging evidence on those, and seem to be reducing overdoses. But there's a tremendous amount of stigma and opposition. Just in general, with harm reduction, there's a belief that it sort of perpetuates substance use or normalizes substance use. But if we think about like the real complexities about why people use substances, the point of harm reduction is to simply keep people alive, reduce harms, reduce overdose, reduce disease transmission. And I agree. The testing strips, I think they're new, so the evidence is just emerging. The issue is that they're considered paraphernalia, so they have to make changes to state laws to allow for those to be legal. Florida does. The issue is like if you're legalizing the test strip substance by substance, you're constantly playing catch up. So now states have xylazine and other substances that are coming in. So there's always sort of a lag about sort of making those legal. But yeah, stigma continues. Stigma is the biggest barrier that we have in addressing anything related to substance use. And then for harm reduction, funding is a big issue as well.
The needle programs also reduce HIV. And anecdotally, I have heard that even though communities might be resistant to them, they actually turn out to be better for the community because you don't find as many needles hanging around in places where people don't want used needles. Anecdotally, I've heard that.
So do you want to hear devil's advocate? Do you?
Yes.
Okay, so on the fentanyl test strips, here's the issue. We're preventionists. We're trying to help people not even engage in a behavior that might lead to their harm or death. The problem with the fentanyl test strips is that fentanyl by its nature clumps together. So if a person does not know how to properly, as a matter of fact, the state of New York has an excellent training on fentanyl test strips. It's not as easy as you take a little piece of whatever your drug thing is that you're using and put it in a little water and stick that fentanyl test strip in and it's clean and you go great. Because you might take the rest of that pill and it actually has clumped together enough fentanyl to kill you. There's a case right here in Duval County where two girls, 17 and 19, split one fake Percocet pill and the 17-year-old died. The 19-year-old survived because the fentanyl had kind of, so I'm not opposed, and as preventionists, it's not that we're opposed, but we don't want people to think that if they have a fentanyl test strip, that they necessarily have a safe drug supply. Because to really do it correctly, you would have to test your entire supply, put water in it, like you'd have to crush the pills, or you'd have to use cocaine, put the entire thing, put water in it, test the entire supply, and then let it reconstitute. So I just don't want you guys to go out and think that if you get fentanyl test strips and you do a simple test that you're necessarily safe. Please, please get educated. You can go to the state of New York's official website. And like I said, they have a really good training on it. On the needle exchange, we are all for a needle exchange. But I want you to hear clearly that's an exchange. If you come in, whether you're a diabetic and that's why you use needles, or you're a drug user, an IV drug user, and you come in and you've got 10 needles and you get 10 needles back, that's fine. But there are also programs around the country that allow people to go in and get as many needles as they want. And what we have found in areas of the country that are doing that particular kind of program, and it's a very subtle difference, I don't remember what the name is, but it's subtly different. But in areas of the country where that's happened, what happens is we find that drug dealers are getting the needles and then selling them. And so people that are already extremely in very difficult financial situations are not only having to buy the drugs, but now they're having to buy the needle from their dealer. So we're fully in support of a needle exchange program, but want you guys to think if what you want is just a needle distribution program.
So through the Department of Health, there is a Narcan program and a fentanyl testing program that's currently in place. And through the Privacy of Life program, UF Health is now providing that to individuals. So Narcan and fentanyl testing strips when the individual leaves. And that's in hope that they do follow the directions that's listed on there. They also get the training not only for the Narcan, but the fentanyl testing, because they don't know what they're buying. And so if there's any way we can help save a life, we're going to try to at least attempt to save that life with some kind of testing strip. And of course, there's more education that needs to be out there. And I want to make sure we understand about the needle exchange too. I mean, there's a lot of populations, a transgender population that could truly benefit from that. The endocarditis cases would drastically be reduced because people not reusing their needles. There's a lot of things, and an individual that goes into the hospital uninsured will go through 6 to 8 weeks of antibiotics. And that's the hospital system that is absorbing that cost, which drives up all the other costs that you may be paying as an insurance provider. So there's a lot of benefits in being able to do needle exchange. And I know that's gone before City Council and they've danced around a couple of ordinances. And so, if your heart is heavy on that, when you hear about ordinance coming up around harm reduction in the City Council, I truly recommend you showing up and having your voice heard.
Can I say one more thing
Yes.
about like Narcan? So we do 3 free standing online Narcan trainings you can come to, and we mail the Narcan to your home after you take the training. And you don't have to take the training. It's not a hard medicine to administer. But what we have found is we ask 3 questions. We ask a lot of questions on the pre, but not that many. I think it's like 11 or 12 questions. But 3 of the questions are you likely to carry your Narcan? You do this on the pre and the post. How likely are you to use it? And what is your confidence that you're doing it right? And in all 3 of those questions, we see somewhere between a 25 and 50% increase, from before when they take the pre-test to the post-test. We have somebody who comes and speaks to some of our groups whose boyfriend died right in front of her. She had Narcan, but she was afraid to use it because somebody had just handed it to her. And when it came down to it, she was afraid to administer it. It's not a hard drug to give somebody, but there's some little tiny tricks that will boost your confidence if you come to this free training and we mail the Narcan to you. So it's like the harm reduction act of having the Narcan, gosh, we so fully believe in. But you're way more likely to use it, and you're way more likely to use it right if you go ahead and just take one of the trainings. So we really advocate training coupled with that harm reduction act of the Narcan kit. Does that make sense?
All right, one more question? Go ahead.
About the Narcan, is there any risk to the individual if they're not actually experiencing an overdose and you did administer Narcan?
None at all. There's no risk. We have been authorized to say we can even give it to a 6-month-old child. Okay.
Okay, so we really have one more. If anyone has one, go ahead. And then we'll go ahead and close it out.
Okay, I saw a little bit more on the emotional side of things rather than the educated. Next month will make 2 years since my dad overdosed on fentanyl. So my question here is, how do we get just the general population, not just the doctors, the police, to really understand that this isn't just another drug addict on the side of the street. This is parents, brothers, sisters, family. How do we really just get them serious about it and how serious this crisis is?
We get people like you to tell your story.
So there is a public alert notice that has gone out through the Department of Health, Children and Families, and it talks about fentanyl and how it kills. And and how to reach out to individuals. And I'll make sure that these copies end up getting back to the school. But on it itself, it has QR codes that allows the individual to seek help for themselves or have questions or find out about Narcan, how to get that. There's a large program in the state of Florida called I Save Florida, where individuals can just go to a certain provider and pick up Narcan free of charge, no questions asked, and be able to know that if they walked into a fast food industry and walked into the bathroom and saw someone on the floor, they could apply the Narcan and hopefully save that individual's life. Now, if they were simply having a seizure, and I apologize for saying simply, if they were having a seizure, it's not going to interfere with anything that was going on with that individual. So at least you have the ability of helping that and then calling 911. I've heard many of stories where people have walked into businesses and found someone in the restroom and felt absolutely helpless, knowing that they had heard something about this Narcan, but yet didn't have anything with them. So let's do some closing comments. Call to action, or what you would like the audience to be able to leave here tonight knowing about pill mill to fentanyl. Go ahead.
Okay, I'll start. I'll close with another brief narrative. This is a true story, also from the Joplin, Missouri site. So one of the clients in the we also have a family treatment court initiative there, and you usually think of like in justice involved folks of single mother households. Well, this is a single father household where the mother was away getting treatment, and the seventh grade son knew where the father hid his stash of marijuana, and he kept it in just a little baggie, like most Americans that have marijuana do, and it was in the top drawer of his dresser. And he also, there was several other empty bags that were like, from other times where he had, bought a half or a quarter ounce of weed, or also he had bought a handful of Xanax a couple of times. Well, the seventh grader stole a couple of buds out of the stash and put it in one of the empty bags. The empty bags, the empty bag had been the bag that the Xanax had been transported in, and the Xanax had been laced with fentanyl. So I don't know if you ever noticed it, but like, have you ever noticed like at the end of a prescription bottle on your last pill, there's like all the dust done at the bottom of it because of it getting bounced around or moved? Well, same thing on the bag. So he transported the marijuana to school and crushed it up and rolled a joint. And 3 seventh graders went to the emergency room. 1 died of a fatal overdose. So the fentanyl can be through even osmosis, through something as innocent or simple as that. And it's I think a lot more far-reaching. And I don't really know. I was searching for an answer to the last student's question of, well, what can we do? And I think maybe the answer is when it kind of hits a critical mass point and we call enough attention to it, and I think we're nearing that, because I have to be careful and not talk about this in an impersonal way, because in 2 of the states, the police officers that run the crisis intervention program or whatever, the COSAP grant or whatever it is that it's delivering the treatment, they themselves have had family members that have recently overdosed and sometimes passed away. So it's I think it's is still a stigma, but I think it's a lot more prevalent than we all realize for most of us.
I think we've come a long way in talking about it, and thank you for sharing your story, and I'm so sorry for your loss. It is something we have to remember. The 112,000 those are people, those are families, those are individuals, and this crisis has just been absolutely devastating. I think we have to remember that addiction is preventable and it's treatable, and we actually know what to do. We know how to prevent it. We know how to treat it. We just have not had the political will to invest the type of resources that are necessary. We're talking about the investments have been historic to date. There's large amounts of money coming out of the federal government and through opioid settlement funds to address this crisis. This is a crisis for which the consequences cost $1 trillion a year. We are throwing like pennies at this issue in comparison. So there needs to be much greater political will I think for policymakers, it's really important to reject the inclination to move towards criminalization to address fentanyl. I think there is, while we've been speaking about it more compassionately and some of that stigma has been reduced, our policies haven't necessarily followed. We haven't gone all in on a public health approach. We're still very much straddling a criminalization approach. And I think there's, in the age of fentanyl and this frustration with the unrelenting overdoses, there's a strong inclination to double down on criminal penalties, and that is going to cause a lot of harm. And that's a lot of the policymaker conversation that's happening right now at both the state and the federal level. And so I think that we need to keep reminding policymakers that this is a priority. This is beginning to become like a voting issue, which it really hasn't been before because people have been afraid to talk about it. And so the more that we're out there talking about it and sharing stories and the impact that it has is really, really powerful. We say the recipe for policy change is data and research and evidence plus stories. And a lot of times those stories carry a lot more weight than any mounds of research we can demonstrate to a policymaker.
Yeah, that's a good word, Lindsay. And I since I work more locally and regionally and just at the state level, I just, your story is crazy. And really it is, I think, adding to what you said, Linz, I think it can really be life-changing. The truth is, according to the data, I want to say 65% of the deaths in Duval County in the last year were white males. And they were white males between the ages of 28 and 45. So one of the reasons we see $1 trillion in cost a year from this crisis is lost lives and taking actuarially those lives out of the employment system. You know, those are people that won't be working later and won't be putting into the Medicare and Social Security system and all that kind of stuff. I mean, this is going to be a crisis for you guys for another 50 years. So we need to understand this is your brothers and sisters and moms and dads and cousins and friends. And, you know, it's a different crisis than the crack cocaine crisis back in whenever that was, you know, and this is all of us. And we have to couple together. I'm super pro prevention because I feel like if your daddy didn't, you know, get involved in this stuff to begin with, then he wouldn't have had an overdose. And obviously the best way to prevent it is not to do it. But we also have to deal with compassionate care and great policies and excellent resources, folks that already are engaged in it, and people that trip up along the way and get involved. And you guys are, you know, this is your future. So I beg you to get engaged and get involved. Thank you guys for being here tonight and taking your time, and thanks for sharing your story.
I guess I'd just like to say that because of the ways that our brains are, we like abusing drugs, and we're not evolving out of that. And as long as we are demanding drugs, people are going to make them. Mm-hmm. Greedy people are going to make them and are going to take advantage of us. So these particular drugs that these days that came from drug companies, we can think of them as a tool. I think probably that their intentions were good, but they messed up when they decided to hide evidence that they had that the drugs were addictive. Now anybody can make these drugs who knows a little bit about chemistry can make these drugs. And so I think they're always going to be there if we're demanding them. So from the supply side, I think they're going to be available as long as we demand them. We need to focus on prosecuting the people who are making them and distributing them, and not the people who are the victims. And the things that perhaps we can do on the demand side, we talked about some of those, those are the prevention things that we can do. Try to address mental health, try to address all of those things, those hardship and despair kind of issues. And then of course educate people so that they don't try it. You guys are probably not likely to go out and, you know, take a drug off the street when you don't know what it is because you have some education about it. So those are the kinds of things that we need to do. And then of course, reducing the stigma so that people will get treatment when they need it.
Thank you. Nick, would you like closing remarks?
I want to thank everyone again for coming tonight. And in particular, I'd like to say a huge thank you to our moderator, Rico, and to our 4 panelists for sharing their experience and their expertise.